All right, if you're a future clinician, you're in the right place. We're about to do a super high-yield dive into one of the most dramatic drugs you'll ever use in emergency medicine, adenosine. Let's jump right in.
So picture this. You've got a patient. Their heart is just hammering away, a chaotic rhythm that could turn fatal any second. You have to act, and you have to act now. Well, believe it or not, the answer to this terrifying question often lies in one single syringe. Here's our game plan. We're going to break this all down into 6 parts. We'll start with the fundamentals, then get into how it works its magic on a molecular level. We'll cover its lightning-fast trip through the body, talk about who should not get it, master how to give it, and then wrap up with a clinical pearl you'll definitely want to remember for your exams. Okay, first things first, the absolute basics. What exactly is this drug, and when do we even think about using it?
So adenosine is technically an antiarrhythmic, but it's kind of in a class of its own. It doesn't really fit into that neat class 1 through 4 system that you're probably studying. Its whole mission, its entire purpose, is focused on one tiny critical part of the heart's electrical wiring, the AV node.
The main reason we grab a syringe of adenosine is to slam the brakes on PSVT. That's a specific kind of dangerously fast rhythm starting above the ventricles. And you know what really shows its power? It even works in really complex cases like Wolff-Parkinson-White syndrome, where there's this whole extra electrical pathway causing all the trouble.
So how in the world does adenosine stop a heart that's going a mile a minute? Well, the best way to think about it is like a biological Control-Alt-Delete for the heart.
What it's really doing is performing a chemical cardioversion. It creates this super brief, totally controlled pause in the heart's conduction system. And that pause gives the heart a chance to just reboot. It's a hard reset, right at the molecular level.
Let's walk through this step by step. First, adenosine zips in and binds to these A1 receptors on the heart cells. That's the key in the ignition. This immediately throws open the potassium channels, and potassium ions just rush out of the cell. Now, with all that positive charge leaving, the inside of the cell becomes more negative. We call that hyperpolarization, and that makes it way harder for the cell to fire. At the exact same time, it blocks calcium from coming in, which further shuts down electrical activity. So what's the end result? A temporary, complete block at the AV node. And that's what breaks that crazy short-circuiting rhythm of SVT.
And this leads us to what is, honestly, adenosine's most incredible feature. Its speed. I mean, the way this drug moves through the body is the key to everything, both its power and its safety.
Just look at that number. Less than 10 seconds. Some studies say it's more like 2 seconds. It's wild. Before you can even blink, half of the drug is already metabolized and gone. This ridiculously short half-life means its effects are intense, for sure, but they are incredibly brief. And that is exactly what you want when your job is to momentarily stop someone's heart.
And this table, right here, this explains why that half-life is so crazy short. You give it IV, so absorption is instantaneous. But here's the magic part. It gets metabolized right there inside our red blood cells and the cells lining our blood vessels. This is so important because it means the drug doesn't need to get to the liver or kidneys to be cleared. Its action is super predictable and incredibly fast. Okay, we've seen how powerful it is. Now let's talk safety. Because this drug is so potent, you absolutely have to know when not to use it and what to warn your patient about. All right, on the left, these are the absolute do not pass go situations, 2nd or 3rd degree AV block or 6 sinus syndrome, unless of course the patient has a working pacemaker. Pushing adenosine here could lead to a really prolonged, dangerous heart stoppage. Then on the right, these are our big red flags. The number one thing to look out for is asthma. Adenosine can cause the airways to constrict, so you have to be extremely careful with these patients. And I'll tell you what, the patient is definitely going to feel this drug. It's very common for them to get this sudden wave of warmth, this facial flushing, a weird sense of pressure in their chest, and feel short of breath. It can feel really scary for them, but the key word to remember and to tell them is transient. Thanks to that sub-10-second half-life, all those feelings are gone in less than a minute.
Now for the hands-on part. Knowing how to give this drug is every bit as important as knowing when to give it. Get this wrong and it won't work.
For adults, the protocol is pretty straightforward. You start with a 6 milligram dose, pushed fast. If the rhythm doesn't convert in a minute or two, you come back with a bigger 12 milligram dose. Now I have to stress, this is for adults. Pediatric dosing is totally different. It's based on weight, and you have to consult very specific pediatric guidelines.
Your technique here is absolutely everything. You cannot, I repeat, cannot give adenosine slowly. It has to be slammed in as a rapid bolus over just 1 or 2 seconds, and you have to immediately follow it with a fast saline flush. So why all the rush? Well, you have to get the drug to the heart before it gets eaten up by the enzymes in the blood. And of course, all of this has to happen while the patient is hooked up to a continuous ECG monitor, so you can literally watch the drug work in real time.
All right, let's wrap this up. We're going to finish with the highest yield points you need for your clinical practice. And yes, for your exams. Communicating this to your patient is just crucial. You need to tell them exactly what to expect. Something like, okay, you're about to feel some really odd sensations, maybe some chest pressure, but I promise you, they will be gone in under a minute. The reset button analogy, it works wonders. It's simple, it's accurate, it makes sense. And always, always ask, have you ever had asthma before you even think about pushing that plunger?
And finally, okay, lean in for this one. This is the kind of detail that separates a good clinician from a great one, and it's a favorite for exam questions.
Here it is, the caffeine connection. Chemicals called methylxanthines, which you know is caffeine, are adenosine's natural enemy. They literally sit on the same A1 receptors and block adenosine from doing its job. So what does that mean for you? If your patient just pounded a couple of large coffees, your standard 6 milligram dose might do absolutely nothing. You may need to use a larger dose. It's a classic board exam trap, but more importantly, it's a critical clinical reality.
So there you have it, adenosine. It's a drug that can literally stop the heart to save a life, and it does its job in just a few seconds. It's an incredibly powerful tool, a fascinating piece of pharmacology, and something you will absolutely see in your career. The only question left is, after all this, are you ready?